Good morning.
Good morning.
How are you today?
Good.
All right, guys. Today we're going to concentrate mostly on specialties. Okay. Tray setups, procedures, and then I'm going to look and see what my other students told me um, was on the test, and then we're going to look at that too. Okay. Okay. So let's see. Did you guys have a chance to take any of those tests that I put up?
I haven't yet. I'm still finishing up doing stuff for infection control.
Okay. Did you take those tests?
I haven't taken those tests. I've just been going through all the PowerPoints and making like note cards and stuff.
So a really good way to help yourself is to take the tests and see what you know and then concentrate learning what you don't.
Okay.
Because you don't really know what you know yet. Do you know what I mean? Like, so what I mean is kind of, I don't want to say study backwards, but so if you have a reading comprehension paragraph, okay, and you're supposed to read the paragraph and then answer the questions, the best way to do that is read the questions first. Then when you're reading the paragraph, you're going to know what you're looking for. So my suggestion is take the test, see what parts you're weak in, and study those, because the ones you're getting right, like 100% no, those are the ones you know. You really don't need to study them if you already know them.
That
Okay.
makes sense.
So, I mean, listen, I'm just saying this is how I study, and I am a really good test taker. And I think a big part of the problem with these boards and with any standardized test is that nobody ever shows us how to take a test. Okay. So, again, going back to this paragraph that you would have like on an SAT or something, you would read the paragraph and then you'd get to the questions and then you'd go back to read the paragraph, which takes double the time, right? If you scan through the questions first, know what you're looking for, and then read the paragraph with the intent to find what you're looking for, it's going to take you half the time. And the problem with most of these tests is that you run out of time. All right. So you get yourself so wrapped up around a question that you can't figure out the answer to that you end up missing ones that you really know. Okay. So again, just a suggestion. But it's how I take tests, and I've always been a really good test taker. So, okay. So we're going to start out. I'm going to look, well, okay. I don't know. I'd like to get through all of this right here today. That's the plan. All right. To kind of fly through this. General dentistry, I normally wouldn't go over it, but the reason that I think we should go over it is they're going to ask you questions about amalgam setups and amalgam procedures and composite procedures. And for those of you that don't work in ortho, which I know there's one or two of you, it's going to be a problem. So let's just get through it real quick and let's see where we are. As far as anesthesia goes, does everybody understand the different types of anesthesia and the different types of getting numb? Let's start there. What needle do we use if we're getting numb on the bottom?
Can use short and longer too.
Say again?
Short and longer, both.
For the bottom?
Yes.
So it depends what kind of procedure we're doing. If we're
Yes.
if we're doing a nerve block, what size needle?
I'm sorry?
If we're doing a nerve block on the bottom,
Longer.
we use a long needle. And where does a nerve block get numb from?
The back and like in the last molar.
Huh? And where does it get numb to?
I'm sorry?
So if you do a nerve block, it gets numb all the way from the last tooth, if it's your wisdom or whatever, all the way to the central incisor on the bottom. Okay, so if you're putting on topical, where do you put it on?
Exactly in the two we work.
I didn't understand what you just said. I'm sorry. If you're getting numb on the bottom, you dry the area all the way in the retromolar area, and that's where you put your topical, because the needle goes all the way back here and it gets numb all the way to here. Okay. So if you were getting numb on your lower right, 32 all the way up to 25 would be numb. Okay. Does everybody understand that?
Yes.
Okay. And we're going to be using a long, it's usually yellow, but 27 gauge needle. All right. And what if our patient has no contraindications? What kind of Novocaine are we using on them? What kind of numbing medicine are we using on them?
Lidocaine.
Tell me the whole thing, not just lidocaine. Tell me everything. If you were to write it in your chart, how would you write it? Lidocaine 2% with epi 1 to 100,000.
Okay.
Okay. And what color is that cartridge?
Red.
Red. Okay. It's on the test. All right. What if the patient has some sort of heart condition, myocardial infarction, if they have high blood pressure, then what are we using?
Carbocaine.
Right. So what's the generic name for carbocaine?
This is 3%.
Without epi.
Yeah.
All right. And the generic name for carbocaine is mepivacaine.
Okay.
All right. And what color is that cartridge?
Gold.
It's not gold.
It's not, oh no, it's like not yellow. I don't know what is this color.
Okay. I'm sorry, guys. Give me one tiny second. It's tan. Okay. Give me one second. Okay, so if we're doing infiltration, you said sometimes we use a short needle for the bottom, right? And we always use a short needle for the top. And what color is that short needle typically?
Blue.
No?
Blue and white, no?
Are you talking to me?
Yes.
I'm sorry, what did you say?
Blue and white.
Oh, blue? Blue, yes.
Blue.
Okay, but what gauge is it?
25?
No. So here's the thing. The yellow is a 27 gauge.
27.
Blue, no, that's the yellow.
Yes.
The blue is 30 gauge short. Okay. And if we're going to do, so when we do the top, we use the 30 gauge short blue needle. And we would normally use either lidocaine or carbocaine, right? But if we're infiltrating the bottom, what's the best thing to use if we're infiltrating? We still use that blue short 30 gauge, but what type of carpule? Either septicane or articaine, and that is gold. Okay, and that's 4%, 1 to 200,000. All right. So if we infiltrate, where do we infiltrate on? Maxillary or mandibular?
Maxillary.
No, we infiltrate on the mandibular. Okay, infiltrate. So we're doing the nerve.
Oh, the last
one. Okay. But if we're going to use a short needle on the bottom, that means we're just going to get it numb right around that tooth instead of doing nerve block. And that's called infiltration. Okay. And that's when we're going to use that gold cartridge. All right. It's on the test, so make sure you study it. All right. So for general dentistry, instruments. Okay, let's talk about that. Let me not do this slideshow for this. Let's talk instead about the instruments for this. Okay, instruments for different procedures. They're going to ask, what is the setup for a composite? Okay, do you guys remember Black's classification of cavities? We've talked about it every week, right? Tell me you remember. Even lie to me if you don't remember. Okay, Black's classifications of cavities. Class 1 is Pitt and Fisher. Everybody remember? Class 5 is a buccal or a lingual right along the gum line. Cervical third is igniting a fire. Does anyone remember? This is our last class together, guys. So I just, I really need your input, because if you don't remember it, I got to teach it again. And I put all these tests up and no one took them. So I don't know what you know and what you don't know. I'm kind of working blind here. So, okay. I really need your input. this is our last class together. And then you guys are going to be out on your own taking these tests. And I want to make sure you're prepared, but that's hard for me to do if I don't know what you know and what you don't know. Does everybody remember Black's classification of cavities?
Yes.
Okay.
Yes.
Good. All right. So if we're doing a composite procedure for a class 1, class 2, or class 3, so that's going to be Pitt and Fisher, anterior in between the teeth, right? Let's look at the instruments that we use. Everybody knows what this instrument is? Number 1. What's number 1?
Air water syringe.
What's number 2?
Cotton pliers.
And what's number 3?
A mirror.
And those 3, in addition to, where's the one I'm looking for? In addition to what's number 17? It's a type of one of these.
Scalar.
Not a scalar. Look how skinny it is. Now, all you guys have the 13th edition, right? Is that what we decided?
Yes.
No. Wait, I thought we had the 12th.
Oh no, 12.
You all have 12.
I have 13.
Whoever has 13 in the front of your book is a code. I suggest downloading this, Evolve Elsevier, making an account for yourself and going into this because you have all this available to you that I'm using right now.
Yeah, I did it already.
You did, good. So use the tray setups, use the mock exams, like use this stuff, do the practice quizzes. Like there's 10 questions from each chapter of this book. And there's a lot of chapters in this book, all right? So there's nothing that you don't need to know, all right? So, and this is an explorer, okay? So what does an explorer, a mirror, and cotton pliers make up together?
A basic setup.
A basic setup, okay? On every tray, there's going to be a basic setup. That's a fact, okay? What else do we need for a composite procedure? What instruments do we need?
Plastic instrument.
We need a plastic instrument, okay, or a composite instrument. And one side of it is a what?
Condenser.
And the other side is the plastic instrument, right? So we need that. We need some sort of a matrix setup, right? If we're doing in between the teeth. This is a gold carving knife. Does anyone know what that's for?
No.
That helps around the gum tissue to make sure that there's no excess material. And that's a carving instrument. Everybody knows this is articulator. What is this?
A burnisher.
And what does a burnisher do? On any setup, what does a burnisher do? It's the last thing we use before we,
Smooths out the.
it polishes or smooths, okay? This is a well, okay, for the composite material, for the bond, for that. So let's talk about the patient sits down, okay? There's one more instrument on here too that I want to make sure you guys know. Where is it? You know this instrument? Has a tiny little ball at the end?
Dical.
Dical instrument, okay? And what is dical?
A liner.
All right, there should be some other instrument on here that I don't see with a little tiny spoon at the end. Oh, here it is. Spoon excavator. Has everybody seen this instrument before?
Yes.
Yes.
And what does it do?
Removes decay.
It removes decay. All right, so the patient sits down. First thing we do is topical, right? Then we get them numb, right? So they're numb. What's the first part of a composite procedure? What's the first part of any restorative procedure?
Remove cavity.
Remove the decay, right?
The decay. Yeah.
Correct. So after the decay is removed, what's the next step that we take? So if it's a cavity that has interproximal, then we'll put the matrix band on, right?
Yes.
And then, and if it's not, then we won't, if it's just an occlusal or buckle or whatever. And then what's the first step in the procedure?
Use the edge.
Etch. Okay, and what does etch do? Etch removes the what layer? It's called the smear layer. Okay, so like any debris or like, you know, your teeth get like filmy sometimes. So you put the etch on, the etch removes the smear layer and makes these little like, think of Velcro, almost these little tiny like erosions in the tooth. And then what do we put on after we put on it? Well, so we put the etch on and then we water spray it off and then we dry it. And what are we looking for?
Bonding.
What are we looking for on the tooth after we dry the etch? What should it look like? What should the tooth look like?
Like chalky.
Yeah, like cloudy, chalky. Okay, good. And then we put on, who was it, you, Francia, that said the bond, right?
The bond. Yes.
Okay, and what does the bond do?
Adheres the
It really
material.
bonds the tooth to the composite, right? We need that because composite doesn't bond to a tooth. All right, so etch, then bond. With the bond, we have to put the bond on, spray it to spread it, and then light cure it, typically, right? And then we put the composite in. And what's the first instrument we're going to use after the composite goes in?
Condenser.
The condenser. And that's going to push the material in. And we do it in layers, right?
Mm-hmm.
And then after the top layer, we cure it. Well, we cure each layer. The top layer, we use the plastic instrument to, and the carver and the burnisher to replicate the tooth. And then we cure it. And then how do we check the bite?
The
Articulating.
articular paper.
How many times? As many
The
times as we need to, right?
Mhm.
Okay, so that's our procedure for composite. Any questions about what instruments we use, anything like that? Okay. So does anyone still do amalgam in their office?
No.
Okay, then we really need to talk about this because it's on the tab. So for amalgam instruments, we are talking about first, and it's the same procedure, but it has a slightly different set of instruments, okay? So first we're gonna remove decay, just like we do with composite, right? But some of the decay gets removed with hand cutting instruments, such as a hoe, a chisel. Right? Here's a tanner, no, we don't want a carver. So a gold carving knife, let's see. Here's a hatchet. I don't know if we can get a good view of it, but all these instruments have very distinct lines on them because why, when we do amalgam, what is amalgam held in by? So composite's held in by bonds, right? What is amalgam held in by?
Retention.
Retention. So the areas of the tooth areas of decay that we remove are very rigid. They have like distinct corners to them. Okay, if you look at an amalgam filling on an x-ray, you're going to see that it's very like rigid. It has corners to it. It's very blocky almost, for lack of a better word. So the things that we use to help us remove decay and get that like real rigid area to fill in is going to be a hatchet, a hoe. All right, hand carving instruments. We're still going to use spoon excavator, but we're also going to use things that help to like condense and push and pull and make those areas very rigid. Okay. So the hand cutting instruments are going to be a difference because we use different ones. After we remove the decay, we're still going to put our matrix band on. And then what's our next step? Still etch, right? Because we still have to remove that smear layer. But then instead of bonds, we're going to mix the amalgam. Okay. And the amalgam comes in different spill containers, 1 spill, 2 spill, 3 spill, for depending on how much work you're doing. Okay. So the assistant mixes the amalgam. Have you guys ever seen amalgam mixed?
Yes.
Has everybody ever seen? Has anybody ever not seen amalgam mixed?
Me.
You
Well,
haven't. Okay, so let's
I
look
haven't.
real quick. That's okay. Like I said, I'm happy to show you. I just need to know that you don't know. Okay, so we mix the amalgam and then we place the amalgam in an amalgam well. This is like a 1-minute video, but it'll just show you how it gets mixed.
Activate the amalgam capsule if indicated. Place the amalgam capsule in the amalgamator and adjust the setting for the type of amalgam being used.
I think you did show us this, but it's still like I don't do it, so I don't really
Okay.
understand it completely.
Remove capsule, twist open, and dispense amalgam in well. Fill the small end of carrier first and transfer carrier to the operator, making sure the end of the carrier is directed toward the preparation. Continue this process until the preparation is overfilled.
All right, why do we overfill it? We overfill it so we can hand carve the anatomy back into the tooth. Okay, if it just was like a little ball, it wouldn't look much like a tooth, right? So we have to hand carve the anatomy back into the tooth, and we do that with carving instruments. Okay, let me go back to that. Okay, so we hand carve, so we're using the hand cutting instruments to remove decay. All right, then we're placing etch, then we're removing the smear layer. Okay, smear layer is going to show up somewhere in your test, so just make sure you know that's what etch does, is remove that. Then we're going to mix the amalgam in our triturator or our amalgamator, and we're going to put it into the amalgam well. And we're going to hand it to the doctor with the amalgam carrier. Okay, this is a 1-sided amalgam carrier. Sometimes there's 2-sided. And then we're going to hand them a condenser, same as a composite. Now the condensers are a little bit different. There's a small condenser that has a very flat end. And then there's a large condenser that also has a flat end. So you're going to hand them alternating condensers and continue to hand them. So you'll hand them amalgam to put in, change it with condenser, change it with amalgam, change it with condenser until it's overfilled. Okay. once it's overfilled, you're gonna, we no longer use the amalgam carrier and the condenser. Now we're gonna hand over the carving instruments, okay? And for carving instruments, for that, we're going to use the half Hollenbeck. Have you guys ever seen a Hollenbeck or half Hollenbeck or heard of it? This does the interproximal spaces of amalgam fillings, okay? This does interproximal. There's another instrument called a discoid cleoid, which carves the, computer today. Here's a Tanner carver. That might be what they're using instead of a discoid cleoid. Okay. Either a Tanner carver or a discoid cleoid. That's going to carve the occlusal surface of the tooth. And then the amalgam knife or the gold carving knife is what's going to use to, that and the gingival margin trimmer are going to be used around the margin of the tooth to make things smooth. Then after everything's carved, you're going to use that burnisher. And again, the burnisher smooths and polishes. Okay, so your last step is going to be that burnisher. And then you're going to check the bite, same as you would with composite. Okay, so the procedure for amalgam is a little bit different, but it follows the same basic steps with the exception that we don't need bond for amalgam. Okay, any questions about that? Okay, so let's move on to some of our specialties. All right. You guys understand the matrix band, when we use it, why we use it? Does anyone not understand the matrix band? If not, I can explain it to you real quick. It's very easy. I just want to make sure that you understand it. Does anyone not understand matrix? If you don't, just tell me, because I don't know if you do or not. So everybody understands it. There's no questions about the matrix band. So a matrix band on the lower left, I can also place on what other area of the mouth and not change it. If I make a setup for a lower left, it's the same as making the setup for the last day with me, guys. Think about your x-rays. Setup for the lower left is the same as the setup for the
Upper right.
okay? And in response to that, upper left is the same as the setup for the lower right. So matrix followed the same principles as paralleling technique in x-rays. Okay, if you make a setup for the lower left, it's the same as the setup for the upper right. Setup for the lower right, same as the setup for the upper left. Okay, any questions about that? Okay. Fixed prosthodontics are, let's take the practice quiz and see what you guys know. How about that? All right, fixed prosthodontics include what? Fixed prosthodontics include crowns and bridges, inlays and onlays, okay? Anything that's made outside of the mouth, placed into the mouth and doesn't get removed, okay? Prosthodontics as a whole includes crowns, bridges, and dentures. Dentures are not a fixed prostho, they are a what? They're not fixed, they're what? Anyone?
The mobile part?
Yeah, they're removable. They come in and out, right? Okay. So we have fixed prostho that stay in the mouth and don't come out, but that are made outside of the mouth somewhere at a lab, in your CEREC machine, whatever. And then we have removable prostho, which are also made outside the mouth, but they come in and out. Okay. So Let's take this little practice quiz on fixed prosthos, see what we know and what we don't, and talk about what we don't. A replica of a prepared tooth for the making of a crown is a what? What's it called?
D.
Oh,
D.
as in what?
Pause. D like a day?
Okay, so let's read the question again. A replica of a prepared tooth. Let's talk about what a replica is. So a replica is going to be a model, right? And what is the model of the prepared tooth called? It's not called a post. A post is what you put into the tooth after a root canal to stabilize the tooth. A buildup is
C.
no.
Oh.
Hold on. The buildup is a material that you use to remake the tooth. For example, if there's decay and you need to remove the decay, but you need to kind of re-establish a tooth there, then you use core buildup. Okay, an inlay. What's an inlay? An inlay is after you do, you remove decay on a tooth, instead of filling it, you take an impression, you have the lab make a filling outside of the mouth. The filling comes in just like a crown and you glue it into the area of the tooth. That's an inlay. Okay. What is a die? A die is a replica of a prepared tooth for the making of a crown. Okay. It's called a die. All right. When a fixed bridge is fabricated, the teeth supporting the bridge are referred to as what?
C.
Advantages of CAD/CAM procedures are what are CAD/CAM procedures? Does anyone in their office use a CAD/CAM or a scanner?
No.
No? Have you seen one?
Are you talking about like the iTero scanners?
I don't know the name of your brand, but
Oh,
it looks like a big camera and you put it in the mouth and you go around the teeth.
yeah.
Basically,
It has like a 3D.
yep.
Yeah, we do those at our office for like Invisalign and even
Absolutely.
appliances.
Absolutely. Okay. And you can do them for crowns too, depending on the area. I know.
Yeah, there's like all different ones, I think.
No, you can use the same one for any of them. It just
No, I'm saying like there's different brands for like all of them. I
Oh.
know, like the dentist I go to uses a different one than we use.
Oh, right. There's different brands, but you
Yeah.
can use any brand for any. Basically, it replaces the final impression of your crown, right? Instead of doing a final impression, you take this final scan and then you don't have to take a final impression. Okay. It could be one visit crown and bridge. So if you take the scan and have a CEREC machine in your office, a CEREC machine makes crowns. Okay. You can send that scanner right to the CEREC machine, make the crown, have the patient sit in the chair and put the crown in at the same visit. Okay. It depends how advanced. We don't have one in our office, but I've worked in offices or temped in offices that have them. Okay, so it can do a one visit crown and bridge. There's no need for provisional coverage. You don't need impressions, and it'll reduce tooth sensitivity because you don't have to worry about having a plastic thing in the patient's mouth. Okay, so it's going to be all the options here. All right. What type of retention is used to reinforce a restoration that has been treated endodontically?
C.
Retraction cord impregnated with epinephrine is contraindicated. What is contraindicated? It means it shouldn't be used to the patient with And we just talked about this. A lot of dentistry is crossover. B, a lot of dentistry is crossover. So we use epinephrine in our retraction cord. We use epinephrine to get patients numb. And if someone has an allergy to something, what kind of pen are we giving them?
EpiPen.
Which is what? Epinephrine.
Mm-hmm.
Okay. So there's a lot of crossover in dentistry. If you understand it once, you understand it every time you see it. All right. The retraction cord is placed with a
C.
packing instrument. Okay. The primary function of a provisional bridge is to all right, well, let's talk about this. Do we ever want to increase sensitivity and discomfort ever in a patient? No. So that's never going to be a reason that we do anything. Okay. So that automatically gets cut out. Do we want to shift the adjacent teeth? Is that what we're doing when we put on?
No.
No. What does the word provisional mean?
Something temporary.
Temporary. So is it going to stay on permanently?
No.
No.
So what's
It's
the
D.
only answer that works here?
D.
And maintain the function and aesthetics of the area is exactly why we put a temporary bridge on, right? We want to keep the space open the way it is. We want to maintain the look of it. We don't want our patient to walk around with sensitivity because they have prepped teeth and missing teeth. Like, we want to maintain the aesthetics and maintain the function, right, of that area. When selecting a shade for a crown, it is important to use
Natural light. B.
natural light, okay? The component of a fixed bridge that replaces the natural tooth is what?
C.
D.
C, Pontic. Another name for a resin bonded bridge is a,
The D.
does everyone know what a Maryland bridge is?
No.
So a Maryland bridge has a Pontic. And then instead of taking the two teeth next to it down, like you would for a regular crown, prepping them, you do a tiny prep, and it's held in, if you imagine a stick across the back of a Pontic, and it just adheres to the back of the teeth next to it. So like almost like a stick. Did you guys ever see somebody with a fixed retainer?
Yeah.
You know, that metal. So imagine that, but with a tooth attached to it.
Oh.
Okay. The problems with a Maryland bridge, it's not very sturdy, right? I mean, if you can imagine trying to eat and having it only held on by like one little toothpick, right? So aesthetically it's pleasing, but it's not very functional. All right, let's see how we did. All right, which one do we get wrong here? I might say false to this because I've been finding a lot of wrong answers in here. So let me just look this up. Oh, so they're saying for their CAD/CAM procedure, they're doing an inlay. All right. Well, if you're doing an inlay, then I guess there's no need for provisional coverage if you're making the inlay right there. But you could do a CAD/CAM procedure for a regular crown too. So, I might call false on that. Hold on a sec. Yeah, it's used for all of these. So that's not right. All the options is correct. I'm going to write that down because I've found like 6 questions this week that are wrong. Okay. All right. So this is fixed prosthetics. Okay. What, when you have a bridge, the area that is replacing the tooth is called a pontic. What about the area that are covering the abutments? What is that called on the bridge? You have the pontic, and then you have the crown part of the bridge that's covering the prepped teeth. What's the crown part of the bridge called? It's called a retainer. Okay. Why do we place retraction cord? What does it do? Where is it placed and what does it do? And during what procedure is it placed? First of all, what procedure is it placed during? The making of
A crown.
crown or bridge. Okay. And it's placed around the tooth abutment in what area of the tooth? It's called the sulcus of the tooth. The sulcus of the tooth is the area right around the tooth area that holds the periodontal ligament. Okay, so when your hygienist goes around and takes her measurements around the teeth, she's putting her probe into the sulcus of the tooth to measure how attached the periodontal ligament is. Okay, so we put the cord into the sulcus of the tooth. Why? Where do we want our crown to sit? Our finished crown. Do we want it to sit on top of the gum?
No.
We want it to sit in the sulcus of the tooth, right? Because we don't want to see that line. You know the line I'm talking about, right? People who have ill-fitting crowns, you can actually see the end of their crown and either a metal or the beginning of their tooth so we want it to sit in the gum line. The reason we place the retraction cord is it creates almost a moat around the tooth so that we either get a really good impression or a really good scan of the tooth that goes down into the tooth, because when we make the crown, we want the crown to actually sit in the sulcus of the tooth so that it has a good fit. We want it to go up into the gum. Okay, so we need to move that gum away from the tooth to get a good impression or to get a good scan. Okay, so that's why we use retraction cord. Okay. Provisional coverage. This is provisional coverage means temporary coverage. Okay, this is an expanded function. And this is what we're going to do also when we do crown and bridge work. Okay, we're going to do provisionals or temporaries. Okay, so let's take this practice quiz and see how we do on this. See what you guys know about temporaries. Okay, so what type of provisional coverage is indicated for posterior teeth when a true fit is essential? So we want a true fit, right? Well, take an educated guess for me.
A.
Custom formed. A laboratory prescription is signed by whom?
Dentist.
Provisional coverage of teeth is used to we just talked about this in our last quiz that we took a second ago. Do we want to allow shifting?
I was gonna say, I feel like it's like A or B, but
A or B, yes.
I would say A.
What material can be used for making custom provisional coverage?
A?
These other ones are what? Permanent fillings, right?
Yeah.
Preformed polycarbonate crowns are available in a variety of.
would it be D?
Every patient who receives provisional coverage should follow patient instructions, including should they avoid sticky foods if they have a little plastic tooth on?
Yes.
Yeah.
Should they not be popping dental floss in and out of that area?
So it'd be C.
C.
Regardless of the method used in a dental office, specific criteria must be followed for each fabricated provisional crown or bridge. So they're saying no matter how you make that temporary, you still need to follow instructions.
True.
Okay. They make some of the questions hard to understand, so you really need to like take it down to layman's terms for yourself. I mean, I would say for myself, dumb it down for myself, but I don't, sometimes I really need to step back and be like, what exactly are they saying here? If an aluminum crown is tried in the mouth but not selected for use, it need not be sterilized before reuse.
False.
Please, false. A scaler can be used by a dental assistant to remove excess cement from a provisional crown.
True.
That is an expanded function, okay? The expanded functions dental assistant does not have a major role in the fabrication and temporary cementation of a provisional crown or bridge. Let's talk about the parts of,
False.
yeah, let's talk, what part does the assistant, the RDA, do in a crown and bridge procedure? The doctor gets the patient numb, okay, and preps the tooth. And then they leave. And we make the temporary, pack the cord, help the doctor take the final impression, and cement the temporary. We're doing half the procedure. So we definitely do have a major role in crown and bridge, okay? We do half the procedure ourselves, okay? Yay. Okay, so the only one we had questions about. So when you have a temporary, we have to cover those abutments or they're going to be super duper sensitive. Because when you prep a crown, you get past the enamel into the dentin, okay? And it can be very, very, very sensitive for the patient. Okay, do we want to replace the exact function and aesthetics of a tooth with a provisional? Exact? No. All right, we don't. We don't want our patients to fall in love with their temporaries because then they're not going to like their real crown when it comes in. And it's not going to replace the exact function. We make the crown or the bridge a little bit short so that they're not using it as their main source of eating. Okay. Any questions about this? You guys, I'm trying to kind of fly through stuff that I feel like you guys don't need a lot of help with, and then we'll spend the majority of the time on stuff that I feel like you guys are really not okay with. All right. Removable prosthetics is dentures. Okay. They're not easy to make, but as far as what they are and what we do for them, it's not super difficult. Okay. So we'll take the practice quiz real quick, talk about them real quick. I don't want to do I'll list the PowerPoints for you guys for these chapters anyway, and I'll put them on your classroom, but I don't want to waste time going through because these are I feel like these are easier things, and I'd rather take a majority of time on like, you know, periodontics or endodontics, stuff that you guys don't normally do every day. Okay. All right. So when a denture is relined, an impression is taken using what? What is a reline of a denture? Let's talk about a denture procedure real quick, okay? If a patient is getting teeth out, okay, but they don't want to walk around with no teeth, we make something for them called an immediate denture, okay? An immediate denture is a denture that immediately replaces missing teeth. So we take an impression on the patient, the lab knocks off the existing teeth and makes a denture out of it to the best of their ability. Okay, it's not an exact science. What happens after a patient's teeth come out? What happens to the gums?
They shrink.
They shrink. Okay, first they swell, then they shrink. After the patient's gums have shrunk up all the way, what's wrong with the denture?
It won't fit.
It doesn't fit anymore, right? And we need to do something called a reline in the denture in order for it to fit the patient. Okay, so the reline is done right where? To make that denture fit. The patient comes in the morning, we take an impression using which of these?
Their denture.
Their actual denture. We take the impression right in their denture and then send their denture to the lab to be hard relined. Or we can, I mean, honestly, we can do it too. It's also an expanded function, but not, I mean, I do soft relines for my patient all the time. I wouldn't probably try a hard reline because that's kind of permanent. So, but we use the patient's denture to take the impression, send the denture out to the lab, and then the patient comes back later on that day or the next day to get their denture, which at this point now should be snug in their mouth. Okay. The blank is a component of a partial denture that determines how far it is seated into the plane of occlusion. First off, what is a partial denture? It replaces all of the teeth?
No.
What does it replace? It replaces the missing teeth in an arch, but not all the teeth are missing. Okay, so if some of the teeth are missing in an arch, we're going to do what's called a partial denture. If all of the teeth are missing in an arch, we're going to do a complete denture. Okay, so a partial denture, how is it held in?
It's anchored by other teeth.
It's anchored by the existing teeth. Okay, so the problem with anchoring it by the existing teeth is we need to have something to stop it from seating all the way. So we have clasps that go on it, right? And we have something that we have to prep on the occlusal of the teeth. When we prep something on the occlusal of the teeth, what is it called? We're prepping a what?
Is this a retainer?
So we're prepping what's known as a rest, okay? So the top of the denture is going to have like a little ball that rests into the occlusal of the teeth to help stop it from seating any further, okay? A preliminary impression is taken in the fabrication of a full denture to, so let's talk about the steps of making an actual denture, not an immediate denture, an actual denture. The first step is preliminary or initial impression. Okay. What do we do with that initial impression? We make a what? When we take the initial impression, what kind of tray are we using? A regular stock tray, right? Like one that you take out of the cabinet. Everybody's seen these trays, right? Even in ortho, you use stock trays. They're plastic, they're metal, but they're regular trays. They're not form fitted to the person. They can fit anybody, right? As long as you get the correct size. Those are called stock trays, okay? So our initial impression for a denture is taken in a stock tray, a regular tray with alginate, right? So we take our impression, we pour it up, we send it to the lab, or it is an expanded function, which I did for many years. We make what's known as a custom tray. Has everybody heard of a custom tray?
Yes.
So a custom tray is made out of this initial impression, okay? And a custom tray only fits how many people? One person, all right? That custom tray is what we use to take our final impression for denture, which is the second step of making a denture. All right, so we have our initial impression made in stock tray with alginate. Then we make our custom tray, which is only form fitted to that person. And in that custom tray, form fitted to that person, we take a final impression with something like monophase or Impergam or some sort of heavy bodied or medium bodied impression material, okay, to get a more exact impression. So that's the second step. So we have initial impression, stock tray, make our custom tray, final impression, custom tray. Then we do what's known as an occlusal bite. And they are like pink pieces of wax that fit over the patient's mouth in order to line up where the teeth are going to be, okay? So that the lab knows when they're making their denture where the teeth line up. So you want to mark the canines, you want to mark the centric occlusion, you want to make sure the patient's bite remains the patient's bite, okay? Because if it doesn't, if they make the bite like this, that's going to be really hard for a patient to get used to. They're not going to be able to get used to it. They're not going to be able to change their bite that much. So we want to know what their bite is so that we can, so the lab can articulate a model. Did you guys ever see those big metal, sometimes they're plastic, sometimes they're metal, but they have teeth on them?
Yes.
Like this. They're called articulators, okay? And what the lab is doing with that third wax bite is articulating a model, okay? The next step is they're going to take that wax and put teeth into it. So it's going to come back and we're going to do a wax try-in. So we're going to take those wax teeth, try them in the mouth, and make sure we're all happy with the color, the size, the shape. Make sure the bite is correct. Make sure that the teeth line up properly, okay? Because once they're in acrylic, it compromises it to start changing things. All right, so the wax try-in is probably the most important step because we want to make sure everything is right. And then we deliver the denture in the next one. So the denture, the teeth are set up in acrylic and delivered to the patient with a series of possible adjustments after that. Okay, so that from soup to nuts is a denture procedure. Okay, so the preliminary impression is taken in the fabrication of a full denture to what? Construct a custom tray. Okay. All right. So the preliminary impression is only taken so we can make that custom tray to take the final or more specific impression. All right. And again, how many people are going to fit in that custom tray?
One.
One. How many people can fit in a stock tray?
Oh.
Everybody. I mean, it may be a different size stock tray, but you guys know you open up your cabinet when you're, hopefully you're not taking impressions because you're not really allowed to yet, but if you are, or you've seen someone take them, you open the cabinet, You have a couple to choose from. You try them in the patient's mouth. Whichever one fits, it's fine, right? But a custom tray is only going to fit that patient. Which of the following is not an extraoral factor taken into consideration when constructing a denture? Is the patient's physical health important?
Would it
Yes.
be salivary flow?
So, I would be stuck at this point between B and D because I'm not sure that economic factors is, well, let's try salivary flow. I might say economic factors because it says when constructing a denture. So let's see. A partial denture is held in place on the abutment tooth by the what? The ring that goes around it. What's it called? Maybe we should do this chapter. Does no one know anything about dentures? It's fair if you don't.
It's either rest or clasp.
It's going to be a clasp. The rest is going to be what stops it from seating all the way. If you guys don't know about dentures, I'll do the chapter. I just think this is, I mean, I'm going to kill my dog. She keeps throwing her bone down the steps. I'm sorry. The purpose of a tissue conditioner is to
See?
a metal device built into a partial denture to relieve occlusal stresses is a
Stress breaker or a saddle?
saddle. The success of a removable prosthesis depends on
Would it be D?
the material used for partial and denture bases is
B.
when you get a denture and you open up that bag, what does it smell like?
Acrylic.
Smell like a nail salon, right? Okay. Artificial teeth are constructed from
A.
at this stage, it used to be all B, but I think acrylic or porcelain at this point. Because porcelain's really easy to break. I feel like. All right. Occlusal rims are made of, this is the blank bite that we just talked about. Occlusal rims are the wax bite. The occlusal rims on a denture are used for the records of vertical dimensions. So you want to see where the teeth are going to sit. Okay, up and down. You want to see where the teeth are going to sit. Like it's just a giant piece of wax. Have you guys ever seen it?
Yes.
Okay. Which of the following is not a measurement that is used for evaluating a patient's bite?
C?
Did you say C?
Yeah.
When dentures are not in the mouth, they must be stored in a
A?
An immediate denture is one that is placed immediately after.
Extraction of teeth.
Most partial denture frameworks are made from
C?
A complete denture supported by 2 or more remaining natural teeth or implants is an
Overdenture.
overdenture. All right, because it goes over your natural teeth or your implants. Okay. A denture would be polished on a
D.
Everyone know what these other things are? What's a model term are used for?
It's kind of in the name.
It kind of is in the name. Thank you, Zach. A model trimmer is used to trim models. It's the big thing with this, with the giant disc that goes around and around. What's a vibrator used for?
It's used
For
for
the
pouring the models.
For pouring the models. And what's an articulator used for? Remember I said it for the models to be set up on so you can see where the bite is? That's the articulator, okay? So laboratory lathe. When sending a partial or denture to a lab, it must first be
C, disinfectant.
good. When a patient has his or her denture relined, the patient should be informed that he or she will be without the denture for
D.
8 to 24 hours. Okay, so the reason that I guessed, and I really did guess this, economic factors for this one. So depending on how much your saliva you produce in your mouth, that could be a factor on whether or not a lower denture will remain seated. Okay, because lower denture isn't held in by anything. All right. The upper denture is held in by suction. The lower denture kind of moves around. And if you have a heavy salivary flow, it's going to move everywhere and may actually possibly fall out. Okay, so salivary flow, I think, is going to really make a difference as far as a factor. So for a patient with a very heavy salivary flow, they may want to do an implant supported denture. Okay, that snaps into place like an overdenture because that lower may not hold with a heavy salivary flow. So that is going to matter. When we're talking about, it's not that economic factors don't matter when you're going over a treatment plan with a patient, but the question says when constructing a denture, okay? So I think we really need to kind of delve into the actual question and make sure that we're reading the actual question. A metal device built into a partial to relieve occlusal stresses is a stress breaker. Let me see if I can find that in here. Where are we? I have the 12th edition. And if you're looking at page 874, but in everybody's book, I think it'll be figure 52.3. I still think it's the same figure. All right, this is the part of a removable partial denture. So 1 is the lingual bar. 4 is the clasp, the retainer part of the clasp. Let's see if we can find this. 2C and 5 is the rest that I was talking about that sits right on the occlusal. Is everybody seeing what I'm looking at? Okay, and at the bottom of that page, it says a stress breaker is a metal device built into a partial denture designed to protect the abutment teeth from excessive occlusal loads and stress during mastication. So it would be a stress breaker. All right. And then I think we got the rest of them right. So do you have any questions about the denture procedure? Because I can go over it with you again. So we have, what are our steps again? We have, first step is
Impression?
initial impression.
Initial impression.
And what kind of tray do we take the initial impression in?
Stock tray.
Stock tray. How many people does a stock tray fit?
Everybody.
Anybody? And then with that initial impression, we make what? Why are we taking that? What do we make with that?
Custom?
What?
A custom temporary tray?
Not a custom temporary, a custom tray.
Right.
Okay. We make a custom tray. How many people fit in that custom tray?
Just one.
Just one person. Okay. We're literally pouring up the model of our initial impression. We're taking our custom tray material and fitting it directly to that model of the patient's mouth. Okay. And then once we have fabricated our custom tray, we go to step 2, which is what kind of impression?
Final.
Final impression. Okay. After the final impression, we go to, we make occlusal rims for the
Bite.
wax bite. Okay. Once we take the wax bite, we do a wax try-in with the teeth set up in wax, and then we do a delivery that with the teeth set in acrylic. Okay. Any questions about that? Okay. Does anyone work with dental implants?
I have before.
Okay, so let's talk about the different stages of an implant, okay? So a patient has a bad tooth that needs to come out, and they've decided that they want to get an implant. What are the steps that we need to take in order to get that patient back to functional with an implant? What are our steps? First, we need to do what with the tooth?
Extract.
Extract it. But when we're doing an implant, do we just extract the tooth? What do we put inside to make sure that they have enough
Bone.
Right. So we're going to do a bone graft. Okay. So we extract the tooth, and after the extraction, during the same visit, we do a bone graft and a tissue resorption. Okay. So we fill that area with bone and put a resorbable tissue on top and then suture it up. And then we have to wait
3 months.
3 to 6, it depends on the doctor, but 3 to 6 months. In 3 to 6 months, and this is a typical implant. I'm not saying some doctors don't do immediate implants right at the time they extract, but I'm doing a typical implant, okay? So 3 to 6 months later, what are we gonna do?
Do the implants.
We're gonna place the
Yes, the-
implant, okay? And what is an implant? This is confusing to the patient, so I'm sure it's confusing to you.
Metal screw that goes into the bone.
The implant is just the metal screw that goes into the patient's jaw. I'm looking for I have a whiteboard here that I want to draw a picture on it for you, but I can't find my. What does the implant replace?
The natural tone.
The root.
Not replace the natural tooth. What does it replace?
The root.
The root.
Thank you. Who said that? It replaces the root of the natural tooth. Okay? It replaces the root of the natural tooth. All right? So 4 to 6 months later, we do what?
Exposed it.
We expose that implant, and then we need to put what on it?
Healing
Abutment.
abutment. Healing abutment.
Yeah, okay, a healing abutment. But our final goal is to get a crown on that tooth, right?
Mm-hmm.
Okay, so I know this is a horrible picture here, and I don't know if you can see it. This is the gum line here, okay? This is representing the implant, which is underneath the gum line in the bone. This is going to replace the root of the tooth. Our crown that we put on is going to replace the crown of the tooth. But can these stick together? What do we need to hold them together?
The final abutment.
An abutment.
Yep.
Okay, so an implant consists of 3 parts. The implant itself, the abutment, and the crown on top. Okay, so this whole thing is a finished implant. I'm a terrible drawer, I'm sorry. But does that make sense? So the implant is going to replace the root of the tooth. The abutment is going to replace the prepared part of the tooth. And then the crown is going to replace the crown of the tooth. Okay. And that's an implant procedure. So the procedure is extraction with bone graft and tissue. 3 to 6 months later, placement of the implant. 3 to 6 months later, uncovering of the implant and impression for the abutment and crown. And then 3 weeks later, insertion of abutment and crown. Okay, so it's about sometimes almost a year-long procedure, right, for an implant. Why do we need to wait those months in between? We want to make sure what?
Grow around it.
We want to make sure that the body has integrated these parts, right? So in the first step, when we remove the tooth, we want to make sure that the body integrates that bone. In the second step, we want to make sure that the bone integrates the implant, right? Because if any of these steps fail, we can't put a crown on it and just have someone start chewing on it. What's going to happen? They're going to break their jaw, all right? Or the implant's going to fail. So we want to make sure each step, we leave enough time for the body to integrate, okay? All right, let's take our implant practice quiz. All of the following are true statements about dental implants, except they are significant financial investment. Is that true or false?
True.
There is a risk of infection and other complications. I mean,
True.
we're talking about going
It's
into the
true.
bone, right?
Yeah.
So I would say that's probably true.
True.
The procedure can be done quickly.
No,
No.
this is no.
Probably not. And implants can be challenging for a patient.
True.
There are some challenges I think that patients run into with implants. So which of these statements, which is the
Be
false?
done quickly.
Yeah, I would agree. All right. A surgical stent is used to what? Let's talk about what is a surgical stent. I'm not being gross right now. I wear Invisalign, but this is almost exactly what a surgical stent looks like. Okay. But in the stent is a little hole. Okay. And what is that hole for? That hole is exactly where the doctor needs to what?
Put the implant.
drill to get the implant in the correct spot. Okay. So you send to the lab to make this, or you can make it yourself, a surgical stent so that the doctor knows exactly where to place the implant. Not every doctor uses it, but you need to know what it is. Okay. So knowing now what a surgical stent is, what is it used for?
D.
Help the surgeon place the implant in the proper location. Okay. Especially when you have a doctor that's kind of green behind the ears, like a newer doctor who's just starting. A lot of times they use surgical stents. Okay. Osseointegration is what?
A.
Osseo is bone, if you know that, but I mean, I think it's Latin, so I wouldn't expect that you would know it, but osseointegration is literally the integration of bone or the attachment of healthy bone to the dental implant. Okay. The type of individual implant that is placed directly into the bone is this isn't something you would know unless you've done implants before.
A.
I see why you're picking that one, but I want you to think of other areas of dentistry and pick a different one instead, Zach, my word man. Here's the word I want you to look at. Directly into. What's a part of dentistry where we go directly into something?
Would it be endosteel?
Let's try this one instead, okay? Which of the following is not an endosteel component?
Abutment post?
It's
Well, the stent too, right?
stem.
The stent, right? How many surgical procedures are usually required for an implant procedure?
2.
So we have the extraction. Well, it depends if the patient needs an extraction or doesn't need an extraction, right? So for an implant procedure with a patient that already has bone and they're good to go, it's going to be how many?
2.
2, right? It's going to be the implant placement and then the uncovering.
Right.
Whoa. What are 3 categories of implants? I might even need to look this one up. I'm looking right now. Endosteel. It looks like transosteal, subperiosteal, and endo. Okay. So I had to look that up myself, but that is on page, if you have the 12th edition, 892. But if you look for figure 53.5, for those of you with the 13th edition, you should be able to find it there too. Okay. So it's endosteel, subperiosteal. Endosteel is osseo-integrated implants. Okay. The most common type. The implant is surgically placed in the jawbone. Subperiosteal implant is a metal frame that is placed under the periosteum and on top of the bone. And transosteel implant is inserted through the inferior border of the mandible and into the edentulous area. Okay, so those are the three types of implants. Subperiosteal implants are used most commonly for the support of so if the patient doesn't have a lot of bone, can they get a regular implant?
No.
No, especially on the mandible. Okay, so a patient that's been wearing dentures for a long time, their bone has resorbed and been worn down, and they may not have enough bone left for an implant. But if they got a subperiosteal implant, that could help them to do what? Support a
Denture.
which type of denture? I mean, really
Complete.
mostly B, mandibular complete. Okay, because really when we're talking about, not to say people don't get implant supported upper denture, but again, for some reason, the upper is held through suction by the palate. So people tend to be able to get used to these upper dentures a lot easier. And the lower just moves all around. And if you don't have any bone on the lower, you're just like literally putting a piece of plastic in your mouth and it's just moving everywhere. Because people have a really hard time, especially when they don't have a lot of bone, getting used to lower dentures. So the subperiosteal implant can help support a lower denture. All right, which of the following materials are implants typically made of?
Titanium.
Titanium. Okay. Dental implants are contraindicated when blank is present.
I think it's D.
Which is not part of the implant comprehensive evaluation?
A.
What was that?
A.
Okay.
I would say B, actually,
Mm,
right? Because so the comprehensive evaluation for an implant, do they need to get a cleaning?
no.
Not really. All right. I mean, not to say cleanings aren't important, but you have to make sure the patient is mentally ready to get an implant. I hate to say, but you sort of do need a little psychological evaluation for them. It's a big commitment. They have to be committed to it. If they're a smoker, if they aren't one that are going to come to the dentist on a regular basis, implant might not be an option for them. So you kind of want to get to know what type of person they are also. I could be wrong about that. We'll see what happens. But which of the following is not a reason for taking radiographs for implant evaluation? Can we find this in an X-ray, the height of the alveolar ridge?
Yes.
Yes. Can we find the width of the alveolar ridge in an X-ray?
Yes, I think it's C.
I think it might be C too. All right. Osseointegration or bonding of the dental implant to bone occurs in what?
D.
3 to 6 months. A transosteel implant is used primarily I'm going to tell you when there are no other options. All right. So the transosteel implant is inserted through the inferior border of the mandible. So like up through here. Okay. So we're going into the inferior border of the mandible, which is like the bottom of the jaw. All right. And into the edentulous area. There is an X-ray. Oh no, that's a subperiosteal. Is there one of the? I don't think there is one, but the most common type is a transmandibular staple implant or fixed mandibular implant. These implants are used primarily in patients with severely resorbed ridges and only when no other option exists. I'm reading straight out of the book, so, okay. Home care for dental implants should include
everything.
Dental implant patients should be scheduled for regular recare intervals for D, all the above. Written informed consent is required before implant treatment begins to advise the patient of
D.
all of the above. All right, dental implants are most often indicated when
B.
Yeah, B of these answers, B is the only one that makes sense, right?
Yes.
If a patient has little income, they're not going to want an implant. If the patient can't manage good home care, an implant is not a good option for them either. And if they're in poor health, especially not a good option for them for an implant. Okay. Assigned informed consent is required before the treatment of an implant begins.
True.
True.
The implant prosthesis may be fixed or removable.
False.
False.
Let's see how we did. Let's see what we got wrong here. So if the patient has dense alveolar bone, what does that mean? What
It's
does
hard to
dense
drill
mean?
through.
Dense means thick, right? If someone has thick bone, are they a good candidate for an implant? Heck yeah. The more bone, the better, right? If they have
Mhm.
dense bone, that means that's going to be good. That means once you get the implant in there, it's going to integrate and hold stable. Okay. Does an irregular bony ridge matter when you're placing an implant? Are we placing the implant on the ridge? No, we're placing it under, right? So we can always smooth that irregular bony ridge because we're placing the implant inside the bone, not on top of the bone. So even if it's a regular bony ridge, we can either add bone to it or go through the bone and then smooth the top. Okay, so an irregularly shaped bone is not going to matter to us either. All right, but what is going to matter is a condition that would interfere with normal healing. Oh, so I read this to you and both of these were here. So again, the implants are used for patients with severely resorbed ridges and only when no other option exists. So it should have been all of the options. That was my bad because I didn't read the question properly. Okay. Home care should include, really? No. No, this is wrong. I'm looking at it right here on page 894. It says home care should include single tufted toothbrushes, interproximal brushes, floss. So it is all of the options. Their answer is incorrect. All right. It's all the options. This is correct. Floss, single tufted toothbrushes, oral irrigators, all of them. So don't pay attention to this. Okay. If you guys decide to go in and take these quizzes, be careful because I literally find wrong answers all the time. So if you look at an answer and you're like, huh, look it up in the book. All right. Because I seriously find wrong answers in these quizzes all the time. Okay. And then, so an implant prosthesis can be fixed or removable is actually true,
Oh yeah.
right? Because you can do an implant supported
Over denture.
denture, and
Yeah.
that's going to be removable. Okay. Or you can do a fixed bridge supported by implants. So you could do one or the other. Okay. So you could have removable ones. Like my mom has a removable lower and she has 2 implants right here and here, and it just snaps right in. But she takes it out every night. Okay. So that is, do we have any questions about implants? I think just going over these questions, talking about it, I think for this particular procedure, I think when we get to like endo and oral maxillofacial, I really want to kind of delve more into it, depending on how you guys feel about it. Like, how are you guys do? I really wish you had taken that dental materials test to see how you did on it. So make sure you take those tests, okay? And if you have questions for me after our class is over today, don't feel bad about posting a question on the classroom. I'll still answer it, even though we're not going to be together anymore. And if you guys feel, if you ever need me to open up another test for you, I will. But really, like, these tests are going to be invaluable to you because it's literally how you know what you know. Okay. So don't discount the fact that taking them is a great way of studying. All right. And the way that I created the test for you guys is after you take it, you can download it and you can study from it. All right. You can study from the test, or you can take it as, you can actually take it more than once. All right. So if you take it once, let's say you get a 40 on it. 40 is not a great grade, right? But what does that mean if you get a 40? Before you study, that means you know what?
40% of it.
Yeah, like you already know 40% of the information. That's great. Okay, so it means now instead of having 100% of the information to study, you only have
60.
Yeah. Okay, so go take these tests. If they're worth their weight in gold, believe me. And not even the fact that I take a lot of time to make them, but I do. But even besides that, it's for your benefit. Okay, like I teach this class, and my students take this, and I have every student pass this test. And a lot of the reasons that they're good at studying is because I constantly give them these reviews to take. And when you take something over and you hear something over and over and over, it sticks. It does. There's no way for it not to. Okay. It becomes like, it's like brushing your teeth when you wake up in the morning. Okay. It just becomes a habit. And that's what I'm trying to reiterate by giving you guys these tests. Go in, see what you know, see what you don't know. The stuff you know, you already know. You don't need to study it. Okay. If you know it, you know it. If you guys do composite procedures every day, you know how to do them. Okay. If you work in ortho, you know the brackets, the Palmer, numbers. So that's not something that you need to study. All right. Or not, I'm not saying don't review it, but it's not something that you need to work on to study. All right. So really, I can't stress enough how important they are to take. All right. Let's look at the chapter on endodontics. Let's actually do this chapter because endo is like a rare bird. Okay. Either you love endo or you don't love endo. That's all I can say about endo. Does anyone here do endodontics? I mean, I'm sure some of you, your doctor does it sometimes, but does anyone actually work with an endodontist here? No? Okay. Has anyone ever done a root canal?
Yeah.
Yeah. Okay. It's like this whole other area of dentistry that nobody really, I feel like that and perio are like these weird little areas that nobody will delve into. All right, so let's do our endodontic actual PowerPoint. Okay, and again, I'm going to take all of these from 48 to 60, and I'll put all the PowerPoints into your classroom. so that you can go through and look at them one by one. And if you, so what I would do is I would, go in and take a couple of these review tests. And then if endo keeps popping up that I don't know it, I would go in and review the PowerPoint or go in and reread the chapter or take notes on the chapter or take notes on the PowerPoint and then go back and retake the test. Okay.
Okay.
Okay. That's how, I'm not saying that's how you need to do it. I'm not your judge and jury. I'm just saying what works for me. It might not work for you. Some people like to highlight. I always found when I went into my book and started highlighting things, I ended up with an entire book of highlighted stuff because I never really knew what to highlight. Everything seems important when you're looking, right? Like what's not important that you're reading? I don't know. I'm not good at that type of studying. So I really for me, I like to talk about it. I like to see what I know, what I don't know, and then study the stuff that I just don't know. All right. So the specialty of dentistry that manages the prevention, diagnosis, and treatment of dental pulp and periradicular tissue surrounding the root of the tooth. So what is endodontics? What do you do in endodontics? You do what?
Remove the nerve.
You do root canals. You do part of it. Did somebody say they worked in a pediatric dental office?
I do.
So you do what? What is your endodontics for pediatrics? Pulpotomy, right?
Pulpotomies, yeah.
Yeah. So there's different areas of endodontics. It's not just root canals. You can do an apicoectomy where you remove the apex of the tooth. You could do a pulpotomy with baby teeth. You can do a root canal. So there are different areas of endodontics, and we're going to look at all of them today. Okay. Causes of pulpal nerve damage: physical irritation, extensive decay moving into the pulp, and trauma, blow to tooth or the jaw. So yes, absolutely. If you have trauma to your face, like you fall down and hit your face on something, it's possible that the nerve in that tooth could die and you could need a root canal on it. The other reason for needing a root canal is somebody has a very deep decay. They don't get it fixed. They don't get the filling, and it goes into the pulp of the tooth. Okay. And then at that point, they need a root canal. Signs and symptoms of pulpal nerve damage: pain when occluding. What does occluding mean? Biting, right? Pain during mastication. What is mastication?
Chewing.
Chewing. Sensitivity to hot or cold beverages. We've all felt that. Facial swelling, fever, tenderness of surrounding gums, cracked or discolored teeth. Okay, all these can be signs and symptoms of pulpal nerve damage. Okay. Endodontic diagnosis: subjective exam. Chief complaint: character and duration of pain, painful stimuli, sensitive to biting and pressure. So how do we check somebody if we think they might need a root canal? What are some of the things that we might use to check?
Sensitivity to hot and cold.
Right. So you might use your air water syringe to check, right?
Endo ice.
Endo ice, right? So you spray that. It's the same stuff that's in a, I forget the name of it. It's the same stuff that's in a fire extinguisher. Okay. So endo ice, we might use a bite stick, or it's called a tooth sleuth sometimes, and see when they bite in different areas, if the pain continues, right? We might have them bite on a cotton roll, and when they open, if the pain exacerbates, that might be a cause, okay? Again, cold water, air, okay? Is this keeping you awake at night? I always ask my patients, are you needing to take Motrin round the clock? These are all symptoms that you may need a root canal. Okay, objective examination. This is so objective would mean after we take, the x-ray, or when we look at all of our information, not just inside the mouth with our eyes, the extent of decay. Okay, if we take an x-ray and the decay goes down to the pulp or is right near the pulp, we know, hey, that probably needs a root canal, right? Periodontal conditions like periodontal disease or like if somebody hasn't had a cleaning in a long time and they have tartar below the gum tissue, or the gum tissue is starting, you can see the PDL or the gum tissue starting to separate from the tooth on the x-ray, okay, it may be pulpally involved at that point. Extensive restoration. So we talked about last week putting a liner, putting Di-Cal at the bottom of the restoration. If you go back to your notes and you notice that the decay was severe enough to put a liner, the possibility is always that that patient may at some point need a root canal. It means it was close to the pulp, right? So you can look back and if they have a huge restoration on that tooth and there was pulpal involvement at the time of the restoration, they could at some point need a root canal. Tooth mobility. Okay, what does that mean?
Tooth is loose.
Yeah, the tooth is loose. Okay. And that is usually they're talking about from trauma. Okay. If the tooth is loose from bone or periodontal decay, chances are we can't save it with a root canal. Okay. Depends on the mobility of the tooth. But if it's very loose from like you have periodontal disease and the tooth is like mobile, chances are root canal is not going to save it. So tooth mobility from, trauma or from slight periodontal issues. All right. Swelling or discoloration. If someone has a tooth that's turned gray from trauma, or then typically that tooth is going to need a root canal. Okay. And then of course, pulp exposure. If the tooth breaks and you can see the pulp, obviously, again, what is percussion?
Tapping.
Tapping.
Literally tapping. Okay. So this determines whether the inflammatory process has extended into the periapical tissues. The dentist taps on the incisal or occlusal surface with the end of a mouth mirror held parallel to the long axis of the tooth. And if it hurts, that could be a sign that they need a root canal. What is palpation? Palpation is finger pressure. Okay, sort of tapping with, or pushing with your fingers is palpation. All right, this determines whether the inflammatory process has extended into the periapical tissues. The dentist applies firm pressure to the mucosa above the apex of the root. What is another sign that you might see on the mucosa that'll tell you that patient has infection?
An abscess.
An abscess, and it's usually going to look like a little I tell my patients, do you have a pimple on your gum? That's what I say to them. But yes, an abscess, which we can see, right? If it comes out in the form of a pimple, chances are there's something going on with that tooth underneath of there. Okay. Thermal sensitivity is going to be sensitive to
Hot and cold.
hot and cold. Okay. Necrotic, what does necrotic mean?
Dead.
Dead. I'm like, dead. Please ignore me. I'm punchy this morning. Necrotic pulp will not respond to cold or heat. Okay. If the pulp is dead, it won't respond to anything. It doesn't mean that doesn't need a root canal. It just means you need a really good endodontist with a really good microscope to do it. Okay. Because once the pulp is dead, it closes up. Okay. A cold test, ice, dry ice, or carbon dioxide is used to determine the response of a tooth to cold. That's endo ice. Okay. That's what I was looking for, dry ice. Yeah. Heat test, a piece of gutta percha or an instrument handle is heated and applied to the facial surface of the tooth. All right. And that's going to be the heat test. Electric pulp testing, a small electric, where did I go? A small electric stimulus is delivered to the pulp. Factors that may influence reading include the patient has extensive restorations. When we talked about doing amalgam films, we talked about galvanization, right? And so sometimes these metal fillings can send off like electric shock, especially when they're put with something else that's metal. So that may affect an electric pulp testing. But if they have extensive restorations, if the patient has teeth with more than one canal. Failing pulp produces a variety of responses. Control teeth don't respond as anticipated. There is moisture on the tooth during testing, and the batteries in the test are weakened over time. So there's a lot of factors when you're talking about electric pulp testing, okay? Radiographic imaging, always important when it comes to root canal. This is x-rays, okay? The initial radiograph helps us find the diagnosis. The working length image to determine the length of the canal. So while you're doing a root canal, you're going to be taking a series of x-rays in the mouth as well, okay? The doctor will usually start out drilling a little to get to the pulp and then hand filing, okay? And he'll use K-Flex hand files to hand file the canal out of the tooth. Once he does that, you want to use an apex indicator to make sure that you got to the root of the bottom or the apex of the root. And then you want to put something in there to make sure that you can, sometimes they keep the file in there and then take an x-ray just to make sure they're at the bottom of the apex, okay? So an apex indicator connects to a file and then tells you how far down you are in the canal. So you can get almost an exact location using one, all right? Final instrumentation image is for the final size files in all the canals. Root canal completion image is taken after the tooth has been temporized, so after the gutta percha is put in. When you see a final x-ray, you notice how the canals are all radiopaque, right? They're filled with, does everybody know that they're filled with gutta percha? A material called gutta percha that is radiopaque to x-rays, okay? And it's like this orange cone-like material that gets packed into the canal and then shows up as an image on our x-ray as being completely filled. And we can tell during that final image that all of the canals have been filled, okay? A recall image is taken at post-treatment evaluations. So when they're ready to do the core buildup or the post and core in the crown, we might take another x-ray image, okay? Okay, we're going to talk about instruments for root canal too after we're done this. Okay, so don't, if you're worried about like you don't know any of the instruments, we're going to talk about them. Requirements of radiographic images must show 4 to 5 millimeters beyond the apex of the tooth and surrounding bone or pathologic condition. Okay, so these x-rays, it's really important when you take a PA in endo or periapical x-ray in endodontics that you get below the apex of the tooth. Okay, we don't care so much about the crown of the tooth in this x-ray, we care about the apex. It must be an accurate image without elongation or foreshortening. It needs to be an exact image. What happens if that x-ray is elongated or foreshortened? We're going to have the measurements wrong, okay? Must exhibit good contrast so that all pertinent structures are readily identifiable. All right, we need a good x-ray. Diagnostic conclusions, either we have a normal pulp, so no subjective symptoms or objective signs are noted. The tooth responds normally to sensory stimuli and a healthy layer of dentin surrounds the pulp. Pulpitis, the pulp tissues have become inflamed. Reversible pulpitis, the pulp is irritated and the patient is experiencing pain in response to thermal stimuli. Irreversible pulpitis, the tooth displays symptoms of lingering pain. If the tooth displays symptoms of lingering pain, what does the patient need? Definitely.
Extraction.
Or root canal. All right. So if we're talking about, this is before the root canal is done. Okay. So if the patient has inflamed tissues, we may be able to give them an antibiotic and the tissues can become uninflamed depending on what the particular problem is, okay? But irreversible pulpitis every single time the tooth has symptoms of lingering pain, definitely needs a root canal. All right. Periradicular abscess, this inflammation reaction to pulpal infection may be chronic or acute onset with pain. We've talked about chronic and acute. Acute means strong and right away. Chronic is over time. Tenderness of the tooth in response to pressure, pus formation and swelling of tissues. So again, chronic means a little bit over time. Acute means a lot right away, okay? This inflammatory reaction is frequently caused by bacteria trapped in the periodontal sulcus. We discussed the periodontal sulcus earlier. What is it? We discussed it when we were talking about retraction cord, remember? What is the periodontal sulcus? It's the area what? Right around no takers? The periodontal sulcus is the area right around the tooth where the periodontal ligament stays. It's where the hygienist goes in and does their probing. All right. Think about a moat around a castle. That's your sulcus. The sulcus is the moat. Okay. The sulcus is the moat. It's the area right around the tooth structure. All right. That holds the periodontal ligament. All right. A patient will experience rapid onset of pain, tenderness of the tooth in response to pressure, pus formation and swelling, and again, chronic and acute. A periradicular cyst, this type of cyst develops at or near the root of a necrotic tooth. The cyst develops as an inflammatory response to pulpal infection and necrosis of the pulp. Okay, so this is going to show up on teeth whose pulp has died already. All right, and we've seen it. We've seen it in x-rays. Pulp fibrosis, a decrease in living cells within the pulp causes fibrous tissues to take over the pulpal canal. Okay, so once these fibrous tissues take over the pulp canal, what happens? What does it do to the pulp? Kills it, right? The tooth may also be referred to as non-vital, meaning what?
Dead.
Dead. It's necrotic, right? The term is used to describe a tooth that does not respond to sensory stimuli. Pulp capping. So we talked about this when we talked about doing a regular filling, right? Calcium hydroxide, otherwise known as Dical, right? Is placed over an exposed or nearly exposed pulp to encourage the formation of dentin at the site of injury. Indirect pulp capping is indicated when a thin partition of dentin is still intact. So it's almost near the pulp, but there's still a little bit of dentin, okay? Direct pulp cap is indicated when the pulp is slightly exposed. So either one of these, we can place calcium hydroxide on. And the hope is that the calcium hydroxide reformulates dentin in the area either where there's only a little dentin left or there's been pulp exposure, okay? And that's when we place that Dical or that and do the pulp cap of Dical or calcium hydroxide, okay? So again, this is the start of it. If you're doing a filling and it's really deep, first thing you do is put the pulp cap on. If you only have a slight exposure or almost have a slight exposure, that pulp cap is like the first step. If later on the patient comes back and they're having pain and sensitivity, you go back and you see, we did a pulp cap on this. Clearly, maybe the dentin didn't reform. This patient probably needs a root canal, okay? So you can go back and see that you've done the pulp cap already, but that it didn't help, okay? Pulpotomy, we talked about this for deciduous or primary teeth. This removes removal of the coronal portion of an exposed vital pulp. All right. It is used to preserve the vitality of the remaining portion of the pulp within the root of the tooth. The procedure is commonly indicated for vital primary teeth, teeth with deep carious lesions, and emergency situations. So most of the time you're going to see it in primary teeth, a pulpotomy. Basically what you do is that big part of the pulp that you see in an x-ray, you take that out, but you leave the pulp in the roots alone. Okay, so that's going to be a pulpotomy. A pulpectomy involves the complete removal of the dental pulp, and it is also known as a root canal. Okay, so pulpectomy is a root canal. Pulpotomy is removal of some of the pulp. Okay, pulpotomy is typically in baby teeth. Why? What's happening to the roots of primary teeth?
They're resorbing.
They're resorbing. So a lot of times there isn't a whole lot of pulp in there anyway. Okay, so they're already being resorbed by the secondary teeth or the permanent teeth that are coming up. Okay, so if you remove that big portion of pulp from the top of the tooth or the crown of the tooth, a lot of times that fixes the problem until that tooth comes out. Okay. So instruments and accessories for endodontic procedures, and we're going to actually look at these too, but let's talk about them first. So the hand instruments that we use for endo procedures are, there's a specific Endo Explorer. Okay, and we'll look at what that looks like. The Endo Explorer has a very long, narrow tip. Okay, so our regular Explorer looks like this, or it's a pigtail Explorer, but the Endo Explorer is like just one giant portion, almost like a probe, but thinner. Okay, and without the lines, obviously. So an Endo Explorer. An endodontic spoon excavator, again, very small, but with long, oh, I just had a moment. I can't remember the name of it. Holy moly. I'm like having a moment here. Hold on. I got to find my word here. Shank. Okay, I'm sorry. A long shank, which is the part that connects the working end to the handle. I'm sorry. I couldn't even remember the word for a second. Okay. Spreaders and pluggers. These are going to be for what? A plugger is almost the same as a
Condenser.
condenser. So what are we condensing in endodontics? Gutta percha. Okay. So the plugger and spreader are going to be to spread and plug the gutta percha into the root canal. And then a glick number one, we'll look at that instrument as well. Okay. Hand operated files. We have K-type files. Those are hand files. Okay. If you look, if you're in the 12th edition, endodontics page 905, but for you, Zach, figure 54.11 is a glick number one. It's basically a plastic instrument on one side and a very thin condenser on the other. Okay. You guys see what I'm talking about? And then the endo spreader and plugger is next door in figure 54.10. .9 has the endodontic spoon excavator, and if you flip the page over, you have an endodontic explorer, which again is very thin. Okay. We have Hedstrom files, which are just a different type of file. If you look again on page 905 or whatever page you have. So there's 3 types of files that they use. Well, 4 actually. So they use K-type, Hedstrom, Reamer, and then brooches. Okay, and if you look above these files, there's a picture enlarged of what the tip of the file looks like. All right, so the K files are thicker. The Hedstrom files are very thin at the end. The Reamer files are a little bit pointier. And then brooches, basically, if you turn the page, a dental brooch has little like hair-like metal points coming off of it to kind of grab the pulp and pull it out. Okay. But these are all different types of files that are used in endodontics. Then we have rotary operated files and burrs, gate split and burrs. If you turn to page, forget about the page, figure 54.17. All right, these are gate split and burrs. And these help to clean out the canal and start the canal. And then we have PISO files, which again are in figure 54.18. All right, these are all just different. The PISO files are used to open up the canal, use different sizes to open up the canal. Rubber stops are put on the endo files depending on how long the root canal is or how long the canal of the tooth is. Okay, you don't want to go beyond the canal of the tooth. Otherwise, what will happen? You'll perforate it, right? Have you ever seen a root canal that's gone through a tooth in an x-ray?
Yeah.
Okay. And then paper points are used to dry the canal in between files, okay, after you irrigate it. And what do we irrigate with in endodontics?
Sodium hypochlorite.
Which is also known as?
Bleach.
Yeah, a mixture of water and bleach, okay? Endodontic procedures can be completed in less time because of greater visibility if you use microscope. Okay, operating microscope accomplishes magnification, illumination, and addition of accessories. All right. Medicaments and dental materials, we use sodium hypochlorite or bleach and water. EDTA or ethylene diamantraic acid and chlorhexidine. Does everybody know what chlorhexidine is?
Yes.
Yeah, it's the mouth rinse that we prescribe to our patients who are getting a lot of cavities, right? For it, I don't want to say it sterilizes the mouth because it doesn't, but it helps to disinfect. Okay. Intracanal medicaments are calcium hydroxide and chlorhexidine gel. We have root canal sealers and then the root canal filling material, which are gutta percha points. And these are all used in, like I said, endodontics is sort of a field of its own. Okay. Anesthesia and pain control. What can be a problem when you're dealing with doing a root canal? If there's an infection in the tooth, what is it hard to do?
Get the patient numb.
Yeah, it's hard to get the patient numb, not only in this procedure, but in any procedure, right? Isolation and disinfection of the operating field. How do we isolate the tooth in endodontics? What do we use?
Rubber dam.
We use a rubber dam, right? And really the only other part of dentistry or area of dentistry where we see a lot of rubber dam is where?
Pediatrics.
In pediatrics, right? Because we need to isolate the tooth. However, I really feel like due to the pandemic and all the stuff we're dealing with, I feel like doctors should start to use rubber dam more and more, right? Because it stops a lot of aerosol
We use it on like every patient now.
in pediatrics.
Yeah.
Yeah. When I worked in pediatrics, we used it on every patient too. But because it keeps the area dry, it keeps the patient safe from like think about how many little things you use in pediatrics also, but in endodontics, you have all these little files, right? And the fear is that you may swallow something, right? But if you're using a rubber dam, nothing's going into the back of the mouth. Okay. So, and it also, it creates a barrier from the patient, splatter, aerosol. So you're just working on a minute area. So I really do feel like in the future that may be used more and more, not just with pediatrics and endo, but with all dentistry. Okay, because it's a form of PPE, really. I mean, it's a barrier. Okay. Access preparation is easier, estimating working length. We use an electronic apex locator, which I said locates the apex of the tooth electronically. Debridement and shaping of the canal. Debridement means cleaning, heavy cleaning and shaping of the canal. And then obturation is the filling. Indications for surgical intervention, endodontic failure, okay? Persistent infection, severely curved roots, perf of the canal, fractured root, extensive root resorption, pulp stones, accessory canals that cannot be treated. All of these things are contraindicated to having a root canal, okay? Or like if you get in there to do a root canal and the root is fractured, is that root canal is worth it? Is it? No, it's going to fail, right? And then at that point, the patient's going to need an extraction, okay? Exploratory surgery to determine why healing did not occur, or a biopsy, okay? So I think patients are not realistic when it comes to dentistry, okay? So the tooth hurts. So the patient goes and gets a root canal. Can a patient just get a root canal and then that work is done?
No.
What else do they need?
A crown.
A post and core and a crown, right? Because there's a temporary filling in there. So I always tell them, after you have root canal, your tooth is like an eggshell, right? It's easy to crack, it's easy to break. Like there's not even a permanent filling in it. So like you have to go back and get the permanent filling in the crown, because that is what is protecting that eggshell. Okay, but patients don't understand that. And then they're like, I don't want to, every time I get a root canal, the tooth breaks, the tooth falls, because you didn't follow through. You only did half of what you needed to have done. Okay. In dentistry, a lot of the success of procedures that are done require follow-up. Okay. And I think that that's the disconnect between the patient and the dental workers. I had a patient come in last week who was going to get a 3-unit bridge. So I give him his financial and he goes, I'm not paying for this. I'm like, okay, well, what do you mean? He goes, well, I had an implant done and I thought there was a lifetime guarantee. And I was like, what? And he's like, yeah, it was done 10 years ago. Okay, first off, 10 years. It's not like it was done a month ago. And he had periodontal problems. He never came back to get his 3-month periodontal cleanings. Okay, so he didn't follow through. So your root canal failed. I mean, so your implant failed. Like, it's not like you get something done and then that's the end of it. You know, there is follow-up care in dentistry, and I think that that's part of the problem. So if someone gets a root canal, that's not the end of their procedure. That is them getting out of pain, right? But they need to follow up with the rest of their procedure. All right, apicoectomy and apical curettage, to surgically remove the apical portion of the root with the use of a high-speed handpiece and burr. to evaluate the following: inadequate sealing of the canal, accessory canals, fracture of the root, and pathologic tissue around the root apex. So you can do an apicoectomy on the tooth where you're just removing the apex of the tooth, okay? And then apical curettage is cleaning out the apex of the tooth. A retrograde restoration, this procedure is undertaken when an apical seal is not adequate. A small class 1 preparation is made at the apex and sealed with a filling material such as gutta percha, amalgam, or composite. Okay, so that goes in through the apex of the tooth instead of through the crown of the tooth and is sealed up. I've only ever seen it sealed up with amalgam, and this was many, many, many years ago. But again, I don't do root canals all the time, so, but it can be sealed up with gutta percha, composite, amalgam. All right. Then we have root amputation. This is performed to remove one or more roots from a multi-rooted tooth without removing the crown. So sometimes you'll see this if one canal of a tooth has been compromised, or there is a crack in one root, but not in all the roots, then I've seen a root amputation. A hemisection is the root and the crown are cut lengthwise and removed. Okay. Any questions about endo? We're gonna look at the instruments. Actually look at the instruments now too, and I want to take the little quiz. Endo is again, it's sort of a monster of its own. So do you guys have any questions about it? I think that you understand the process of it. It's just a matter of seeing an instrument and knowing that it is an endo instrument. Okay. So if you think about what a root canal is, the procedure for a root canal is get the patient numb. Then you want to put the dental dam on and make sure it's the tooth is oh God, why am I having such a hard time thinking today? Is isolated. All right, so you want to isolate that one tooth. You're going to remove, well, first you're going to drill in and get to the canal, right? Then you're going to remove the initial pulp of the tooth with a hand file. And then you're going to continue to broaden the canal and go deeper until you get to the apex of the canal. Okay. Once you get to the apex of the canal, you're going to take an x-ray and make sure you're at the apex of the tooth. You're going to fill it in with gutta percha. You're going to burn off the top to seal it. And you're going to put a temporary filling in. Okay. So that's like very quick analysis of how to do a root canal. In between filing, you're going to irrigate with sodium hypochlorite, and you're going to continue to clean out the canal, keep it clean, broaden it until you get it big enough, fill it up and seal it, and then put temporary filling in and wait a couple weeks until the patient is ready to go get their post and core and crown. Okay. So that is like the procedure if asked, which apparently it was on the board. So, let's look at, the tray setup first, okay? Opening a tooth for endodontic therapy. Let's look at that. All right, so this is how you would set up your tray, but if you have this book, you can certainly do your tray setup here. This instrument is called the Glick, okay? And the Glick instrument has a small plugger at one end and a plastic instrument at the other, okay? I'm going to say the glick is going to go here, maybe not. This is the weird thing about these, is they're only letting you put it exactly where it's supposed to go, and it's got to go somewhere. Okay, so, whoops, that was the HVE. No wonder I couldn't get it to seat right. I usually say the basic setup goes at the beginning of the tray. This doesn't want to go anywhere. It's got to go somewhere. Did I miss a spot? Oh, good Lord. I was going to say it should be at the beginning of the tray. Okay, this is an endodontic long shank spoon excavator. Why do we need the long shank on an endodontic spoon excavator? Why the long shank? And what is a shank? How deep do we have to go to remove decay in a pulp?
Deep.
Pretty deep, right? So the shank is the part of the instrument that connects the working end, which is that little spoon, to the handle, which is the part you hold. So the reason we need such a long shank for this is we have to go really deep, okay? This is a millimeter ruler. What do we need a ruler for?
To measure how deep we are into the canal.
And to measure the files, right? Because that's why we have those stops, because we don't want to go longer than the canal, okay? This is an irrigating syringe. Really? Not set up my tray like this. I would not put that irrigating syringe in the front. Okay. So the irrigating syringe is going to put what into the canal of the tooth? Sodium, hypo,
Chloride.
thank you, which is also known as
Bleach.
good. Okay. So we're going to rinse the canal out umpteen times with the sodium hypochlorite. Okay. These are broaches. Again, the broaches are going to be smooth files with little pieces of metal sticking out of them. Think about a Christmas tree. And they are going to be used to grab the pulp and pull it out. Okay. I know it sounds horribly. Okay. Everybody knows what this is. These are college pliers, but the thing about endodontic ones is they have a lock on them right here. Okay. Why is it important for them to have a lock on them? Really? What kind of materials are we working with in endodontics?
Sharp.
Sharp and tiny, right? So when we have something that we're holding, we want to make sure it's locked and it's holding and it's not going to open. Okay, because we're using little tiny things in the mouth. Okay, these are K-Flex files with stops. Okay, and these are going to be used to initiate the start of the canal. All right, so we're going to start out with a smaller file, let's say a 10, we'll go up to a 15, a 20, a 25, until we get to the size of the canal. Which teeth are going to need the largest size files?
A molar.
Molars and
Anterior.
maxillary.
Mhm.
Okay. Because you've seen the canals on the anterior maxillary, right? They're pretty big. Scissors. These scissors are going to be used for what in endo? Sometimes you need them, sometimes you don't. But these are going to be used to cut the dam if you need to. Okay. Sometimes where you place the dam is like over the patient's nose or, all right. So sometimes you may need to scallop the dam. All right. This is another pair of locking forceps, which would explain why the first pair wouldn't fit here. All right. So that's one for the assistant and one for the doctor. These are paper points. Again, what are paper points used for in endo?
To dry the canal.
To dry the canal, okay? This is a burr block with burrs in it. Typically for endo, we're going to be talking about round burrs, okay? And that's going to be to start the process of opening up the tooth. All right, everybody's seen an aspirating syringe, hopefully, at this stage. And then this is an endodontic explorer. Again, it's double-ended, and these ends are really, really long. Everything in endo is very sharp and very long because we're talking about tiny little canals that we need to get to the end of, okay? And again, this is always going to be, your basic kit is always going to go at the beginning of the tray. It's going to be mirror, explorer, and cotton pliers. Okay, so in this aspect, it's mirror, endo explorer, and locking cotton pliers. All right. What is a Woodson? A Woodson is also used in amalgam sometimes, and once in a while in composite restorations. But what is a Woodson? So the Glick is going to have a tiny condenser at one end and a plastic instrument on the other. A Woodson has a flat-ended condenser on one end and a plastic instrument on the other. That's a Woodson. So if asked, a Woodson is typically used for restorative procedures, okay? I wouldn't necessarily put a Woodson here, but they did, so I'm going to put it on the tray. Okay, and this is what your tray should look like. And I will show you what it looks like all set up. Hang on one second. Let me just get to it. No, it doesn't have a picture. That's interesting. Here we go. Okay, so this is what a tray looks like when it's set up for endodontic treatment. Okay. And let's go through these instruments one more time. So we have mirror, endo explorer, locking college pliers. We have a spoon excavator, long shanked spoon excavator for endo. We have a Glick, a Woodson, another locking plier, an endodontic irrigating syringe. We have paper points, a ruler, burrs, air water syringe, aspirating syringe, files, broaches, scissors. Okay? Any questions? No? Okay. All right, let's take our practice quiz for endo and see how we do. An instrument used for final enlargement of the pulpal canal in endodontics is the what? So I'll tell you, Hedstrom file makes everything inside the canal smooth. Okay. Oh, it makes everything smooth. Final enlargement is going to be,
Would it be the barbed one?
brooches. Well, brooches are typically used to remove the final tissue. Not to, let's I believe it doesn't say in here, but I believe this lentillo spiral is a rotary operated, and I believe that does the final widening of the pulpal canal. So let's see what it says at the end. It's not in the book, but I believe it is. All right. During endodontic treatment, the pulpal canals are irrigated with what?
Sodium hypochlorite diluted with water.
Correct. Following irrigation, the canals are dried with
Paper points.
During electronic pulp testing, the tip is never placed on the, what would you not want to burn in the mouth?
The gingiva
Or on,
Metal.
on metal.
because of galvanization, okay? Because you could create an electric shock. All right, after placing the dental dam on a tooth to receive pulp therapy, you would disinfect the dental dam with, I gotta be honest, I don't know that I know the answer to this one. Disinfect the tooth, dental dam clamp, and surrounding dental dam with the use of an iodine solution or sodium hypochlorite solution. So since sodium hypochlorite isn't on here, we'll say an iodine solution. And it is listed in your book on page 909 or somewhere near figure 54.25 for USAC. Okay, so iodine or sodium hypochlorite solution to disinfect the dental dam and clamp. A surgical procedure in which the root canal is filled from the apex is a
Apical?
it's not an apical. It's upside down, so it's going to be
Inverted.
not inverted,
Retrograde.
retrograde. The prepared canals are filled with
Gutta percha?
endodontic treatment is not recommended when the
All of the above.
Or C.
a patient has a medical condition that precludes any dental treatment. I would say C,
C.
because reversible pulpitis, I feel like that can be reversed, right? Let's see. During endodontic treatment, local anesthesia may I would say D. Okay. And the reason I would say that is if the tooth is non-vital, what's the part of the tooth that we really need to numb? Why are we getting a tooth numb? So it's not sensitive, right?
Yeah, but if the nerve is dead.
Right. If the nerve is dead, we don't really need to get the tooth numb. When we do a crown on a root canal tooth, the patient doesn't necessarily have to get numb. The reason we get the patient numb during a crown prep on a root canal tooth is because we're packing cord around the gum tissue and we're prepping the tooth around the gum tissue. So the only thing the patient is going to feel is possibly something around the gum tissue. Okay. But they're not going to feel anything in the tooth because the root is dead. Okay. So for this one, I would say D. And you could use local anesthesia selectively as a diagnostic test to see if the patient is sensitive to cold, or if the if they feel when you're getting them numb, or if the tooth is vital or non-vital. Okay, so I would say D for this one. During pulp testing, if the suspected tooth is the maxillary right first premolar, the control tooth should be the what's the other tooth that's going to act exactly like this one? Or close to like this one.
B.
B. A blank is football shaped and used in a low speed handpiece.
A.
A blank is double-ended and used to remove excess gutta percha from the crown.
A.
A? Did you say A?
Yes.
A general dentist, blank, legally able to perform endodontic treatment, is or is not?
Is.
They are. The standard of care established by the ADA for endodontic treatment requires the use of blank during endodontic treatment.
B.
An inaccurate canal measurement may result in
Perforating. Or all of the options.
All of the options, yeah.
following endodontic treatment, the patient will be referred to a blank for the placement of the final restoration.
B.
A blank is the surgical removal of the apical portion of the root. The surgical removal of the apical portion of the root. Just the apex of the root.
B.
B.
Blank have tiny fish-like barbs along the shaft that are used to remove the bulk of the pulpal tissue.
Broaches.
A.
Blank are used in the low-speed handpieces to place sealer and cement into the canals.
Mm,
I'm pretty sure it's
Yeah.
peso file.
No, I said A.
You said A?
A.
A or hand files?
and then the C would probably be like rotary file, so that's not really something that would be in a low speed handpiece. So it has to
Right,
be B
so
or C.
go
B or
to,
D.
um,
And we already used the B for a different question, so I'm gonna go with D.
it might be the lentulus spirals. Okay, I can picture them in my head. I don't see them in the book is the only problem. But okay, let's see. The removal of the coronal portion of the dental pulp is known as a technique known as a
Pulpotomy.
all right, let's see how we did. Okay, the instrument used for final enlargement of the pulpal canal. So I was right the first time, is the Hedstrom files. Okay, so the Hedstrom files are going to be used for final enlargement of the canal after a Gates-Glidden burr or a Pesso reamer has been used. The H-type file has spiral edges so that cutting occurs only on the pulling, making the dental wall smooth and easier to fill. So Hedstrom files are the final enlargement of the pulpal canal. Okay. And they're on page, or the, sorry, your book is going to be different, Zach. On the page where figure 54.10 is listed, you'll see Hedstrom files. All right, so K files is initial debridement or cleaning of the canal. Hedstrom is final enlargement of the canal. Reamers are to remove dentin structure and smooth and increase the size of the canal. And then broaches are used to pull out the pulp. Okay. This was right. Paper points, yes. Gingiva, we talked, everybody understands why gingiva and metal restorations is the answer here. Because if you put that electronic pulp tester on metal, it could create a shock. Okay. After placing the dental dam, again, iodine solution is going to be used to clean it. Something that starts from the apex and goes up is retrograde. All right. The canals are filled with gutta percha. All of the options. Okay, so is not recommended. So let's look up reversible pulpitis here. So according to our book, reversible pulpitis occurs when the pulp is irritated and the patient is experiencing pain to thermal stimuli. With reversible pulpitis, eliminating the irritant and placing a sedative material may save the pulp. Oh, I read this question wrong. Endodontic treatment is not recommended when, oh, right, we wouldn't want to do endodontic treatment if it's reversible pulpitis. We wouldn't want to do it if the patient has a medical condition, and we wouldn't want to do it if they had severe periodontal involvement. So I apologize. That's my fault. I read this question wrong. So the answer is, and I think one of you answered this way, all the options. So we wouldn't want to do it if the tooth has severe periodontal involvement. Why not?
Most likely gonna fail.
Right, because the tooth is loose. Tooth is probably loose, right? Or at least compromised. If the patient has a medical condition that precludes any dental treatment, we wouldn't want to try a root canal until they figure out that underlying condition. And then if the diagnosis is reversible pulpitis, we want to see first if we can save the pulp of the tooth. So I apologize. I got that question wrong. That's my fault. So what tooth is most like the maxillary right first premolar? In size, in shape, how it reacts. There's only one other tooth in the mouth that acts exactly like the maxillary right first premolar, and that is the maxillary left first premolar, right? The only difference is they're on different sides of the mouth. Okay. Mandibular premolar doesn't even have the same amount of roots as the maxillary. Okay. Mandibular first premolar only has one root. Maxillary first premolar has two roots. Okay. Maxillary second premolar has one root. So the only other tooth that's going to act exactly like a maxillary right first premolar is a maxillary left first premolar. Okay. So that's the tooth we would want to use as the control tooth. Does that make sense? Because these two teeth are exactly the same, just on opposite sides of the mouth. They're both maxillary. They're both first premolars. They both have two roots. They're the only two teeth in the mouth that act exactly like each other. They're the only teeth in the mouth that are exactly the same as the other one. Okay. If we were talking about a maxillary right first molar, what tooth would we use as the control? Maxillary right first molar. Where would our control tooth be?
The right first molar?
If we're talking about the maxillary right first molar, what would our control tooth be?
The maxillary left first molar.
Absolutely. If we're talking about the mandibular right canine, what tooth acts like the mandibular right canine?
The left mandibular canine.
The left mandibular canine. It's the same tooth on the opposite side of the mouth. It's in the same arch. It's the exact same tooth, just a mirror image of it. Okay. What tooth acts like the maxillary right central?
Maxillary left
The
central.
maxillary left central. Okay, so those are the teeth that are going to be used as the control tooth. The same tooth in the same arch on the opposite side of the mouth. That's the only tooth that's going to act exactly like that tooth. Okay. The mandibulars are not the same as the maxillary. All right. I know I didn't teach you guys tooth morphology. It's a very long course, but if you work in ortho, you know those maxillary first premolars get extracted because they're the ones with two roots, and it's easier to move a patient with, it's easier to move a tooth with what? How many roots? One, than it is to move a tooth with two roots, right? So when patients get their teeth out in ortho, what teeth are generally taken out?
The first premolar.
The first premolars. And the reason the first premolars are chosen instead of the second premolars a lot of times is because those first maxillary first premolars have two roots. And it's a lot easier to move a tooth with one root than it is to move a tooth with two roots, right? So that's why those teeth are taken out, chosen. Okay. All right, let's keep going here. So you guys understand the control teeth? It's going to be the same tooth in the same arch on the opposite side. Okay. So if it's tooth number 11, the control tooth is going to be tooth number
6.
Thank you. Yes. Okay. A blank is double-ended and used to remove excess gutta percha from the crown. That's going to be a glick. So let's look that up. I'm sorry, I don't typically teach endo or do endo. So some of this stuff I mean, I know it, but I'm glick number 1, the paddle-shaped end of glick number 1 is designed for placement of temporary restorations, and the rod plugger is ideal for removal of excess gutta percha. Okay, so the rod part is going to remove excess gutta percha, and the paddle side is going to place the temporary restoration. And what are 2 temporary restorations that are typically used in endo procedures? Either it's our favorite temporary restoration, guys. What temporary restoration calms the tooth? We learned about it last week.
ZOE.
Otherwise known as?
IRM.
Yep, IRM. Or sometimes we use something called Cavit. Okay. So a little cotton roll, a little cotton pellet, and Cavit on top. Cavit dries up very quickly. It's like clay colored or pink colored. You make it into a ball, you put it on, and it's easy to manipulate and dries nicely. So, okay. So yes, the Lentullo spirals, I'm seeing them in my head. I don't see them on here. Lentullo spirals are either blue or red. And what the doctor does is dips them into the sealer or the cement, puts them in, and they spread the cement around. So those are Lentullo spirals. Okay. So even though it doesn't say it in here, the spirals are the one that spreads it around. I can't find them in here, but I know what they look like in my head. Okay, so questions about endo. Again, it's just one of those, you know, I don't do endo all that much myself. I've done it a few times in my life. It's not one of my favorite parts of dentistry, but, you know, we do need to know it. So, all right, just try to familiarize yourself as much as you can with endo. I know it's a difficult one, but all right, periodontics is one of those other. Does anyone do perio? Okay.
I've done it before, but it's not my.
Yeah, it's not my. It's actually I've also helped out with perio, but I worked for an oral surgeon for 10 years. I worked for a prosthodontic doctor for 7 years. I worked for an orthodontist for 2 years. So all these things I'm like really familiar with. Perio I've filled in. It's similar to oral surgery, but there's differences. So I'm not overly familiar. Endo I've done a handful of times in my life. So again, you guys get, you know, the bonus of the fact that I've worked in a lot of areas, but these are 2 areas that aren't my areas of specialty. So I can go through them. I know them. I've taught them. They're just not my areas of specialty. So I usually try to pawn those 2 off onto my co-teacher when I teach. So, all right. So that's why I'm making sure I do the PowerPoint slides with you, because I don't want to miss anything on them. It's not something I can close my eyes and just know. All right, periodontics. We're actually moving along fairly well. I'm pretty happy with our. Do you guys want to start this and then take lunch, or do you want to take lunch first and then come back to Perio? You tell me. This is a pretty long chapter, so you tell me.
For me, we can do now.
You want to do lunch now?
No, I
Yeah.
say the charter. I don't know.
I don't care either. I'm asking you guys.
Matter to me.
Okay, well, this is 62 slides. So why don't we take a little break and kind of, because we just got out of endo, which is also like a big, you know, a lot to take in. So why don't we take our lunch break now? We'll meet back at 12:30 and we'll start up with Perio. Okay?
Okay.
Okay. So I'll see you guys in a half hour.
Okay.
Right? Half hour we take?
Yeah.
Okay. I'll see you guys in a half.